Hello, everyone. I'm Dr. Bhaveshkumar Dhamsania. I'm a GP in Gracemere and the Gracemere Medical Centers. Thank you, everyone, for coming along tonight after working hard day in the clinic. So tonight we're going to talk about the coronary artery disease and which investigations is suitable to rule out the coronary artery disease. And I'm pleased to introduce Dr. Sam Sidarta. He is a clinical lead cardiologist at the Rockhampton-based hospital, and also he is an interventional cardiologist. He's also a senior lecturer at the University of Queensland. He is planning in a process to develop the interventional services in Rockhampton. So it's good to see that's a new face in Rockhampton in central Queensland, and who's going to work towards getting a first public the cath lab for central Queensland. I'll just talk a little bit about Sam, that he moved from South Australia. He was working in a Genesis cardiac care before. So he worked over the few years. He worked in a New South Wales, South Australia, and Victoria. He's done multiple publications and written a few chapters in a book. So he's got a quite extensive background about academics and also that's about clinical work he has done so far. He's also completed PhD in a human atherosclerosis in a coronary artery disease, and he worked on utilizing a novel intravascular imaging technologies that can help to identify and utilize the risk for the further atherosclerosis in a human coronary artery disease. So before we go ahead, I would like to acknowledge the traditional owner of the land we are meeting. I would like to pay my respects to the elders past, present, and emerging. So just about the housekeeping, this webinar is recorded. We will send out this recording to all the attendees. We will have a chat functions on the right-hand side. If you just look at it on the chat functions, if you have any questions, you can feel free to write your questions there. We will discuss about the various spectrums of the coronary artery disease, and after that we will discuss about the case-based scenario. That's where the different age group with the different risk factors, when they come to the GP clinics, how we can assess for the coronary artery disease. So during that time, if it's any questions related to that case, we will discuss at that time. If it's something other non-relevant questions, we will discuss at the end of the discussion. Those who want to get the slides that we have here, if you just click on a handout, there are 3 handouts there. So that CADV2 is my slide. There's nothing clinical importance on my slides. But that's the cardiac investigation, which is a very good the clinical reference document that you can find it, like we will talk about down the track, that you can download, and the slides from the Sam, that's also there. So they are in a PDF format. So if you wanted to, you can download from there. Once we finish this webinars, that we will send out the evaluation form. So please do that once. We have a RCGP and ECRM points for this webinar. So if you complete that webinar, the evaluation form, we will send out that the points for the CPDs. So just before we hand over to Sam, I'll just briefly update you about the cardiology health pathway. So we have all the cardiology pathways are in our health pathways, Central Queensland health pathways. It's been 3 years then when we started this health pathways journey. The cardiology is the one that we started at first, and we put it alive for all the cardiologies one. So we have acute chest pain, non-acute chest pain, atrial fibrillations, the cardiac catheterization complications, heart failure, murmurs, dyslipidemia, palpitations, long QT syndromes. So there are a fair few pathways there. So that's you can use it as a reference for the assessment, management, and referral process. It has all the criteria. That's where Queensland Health they generally follow for the putting a triage categories. So you can look at it around those pathways. Just to talk to you about that non-acute chest pain pathways, that this is the pathways that it's already existing there, and if it's any patients come after chest pain follow-up, and if it's not been worked up in the base hospital emergency department, they will come back for a follow-up for organizing some further investigation. So Sam will talk about that, which is the pros and cons of the different modalities, but you can find it as some of the informations here. So some of the limitations of the stress test, he will talk in the details, but you can keep it here, this information as a reference. So for health pathways, this is a username and password. The username is US Central QLD and password is PW Central QLD. So you can keep it in your wallet. Once it's you log in, you can save those passwords, so you don't need to put the username and password for next time. All right, that's from me. So I would like to welcome Sam, and thank you, Sam, for your time, and appreciate that you with us. And Sam is quite keen for education. So he's been involved in a lot of different educations, and he wanted to involve the more GP education. So if it's attendees wanted to have more topics to discuss, feel free to just give us a feedback, and we can work it out in the future. So here you are, Sam. I would hand over to you. Thank you very much again.
Thanks very much, Bhavesh, for your introduction. And welcome everyone to our educational session for this evening. Now, the topic is quite big and quite vast, but I'm hoping that I will be able to cover and try to demystify, some of the things surrounding coronary artery disease. And it's been a pleasure to be invited to give a talk. And I'm fairly new in Central Queensland, so I think I will need to start learning some of your names. So tonight, there are a few things that we will talk about. So first of all, I'll be covering about coronary artery disease, obviously, and try to give you a bit of a overview that coronary disease needs to be viewed really as a clinical spectrum rather than chest pain evaluation per se. We will have a look into some of the imaging modality that is more appropriate for various spectrums, such as asymptomatic coronary artery disease or stable chest pain syndrome, because sometimes things can be quite confusing. And briefly, I will touch the role of high sensitive troponin in rapid ACS assessment. Now, when I was a medical student, or when I was actually still in general training program, or even in the very beginning of my cardiology training program, choosing various imaging modality for coronary artery disease is a bit like this picture. It seems that we just keep grabbing, letters after letters after letters, but it doesn't seem to serve the function or purpose that we're interested in. And sometimes it can be quite frustrating. And there is nothing more frustrating than assessment of chest pain, because there is always this fear that chest pain equals danger. And that is actually quite true in a sense, because in Australia alone, there is, I believe, about 5 million presentation to emergency department on an annual basis, and yet only about sort of 10–15% of that presentation turns out to be true acute coronary syndrome. But yet, amongst all those chest pain that presented, they tend to get tests after tests after tests after tests, but yet after several tests, we don't seem to be progressing forward, but going backward, and that can be quite frustrating. So first of all, we need to understand that chest pain syndrome is actually a clinical spectrum. So it is a clinical spectrum that ranges from asymptomatic cardiovascular disease to stable chest pain and acute chest pain syndrome. And basically, this three disease entity is a dynamic process. They can work from one spectrum to the other in a time frame, not necessarily in designated time frame. Perhaps because when we were in medical student, we're quite familiar with this atherosclerosis timeline. So I think I just want to touch base a little bit about the pathophysiology of various chest pain syndrome. And in fact, I can dedicate almost the whole hour talking about this. But I just want to give you a glimpse of this so at least we can appreciate how we manage this disease that seems to be a mystery. And I hope at the end of this talk, it will demystify some of the myths surrounding this chest pain assessment. So we're all very familiar with the atherosclerosis timeline, beginning from foam cells and the plaque sort of becoming more organized, develop into atheroma, and eventually becomes fibrous plaque, and the growth eventually becomes flow limiting. So often, at least the patients that I'm talking about, they're quite fixated with this atherosclerosis timeline because they think, oh, if I have a 30% disease now, it means by 2 years, 3 years time, it might be 60%. And then once I get to 80, 90%, then, you know, I just need to wait for a few months before heart attack ensues. Well, that is only partly true. And why is that? Because our heart is actually an amazing organ because there is quite a lot of compensatory mechanism. So there is this concept called ischemic cascade, which basically states that if you can see my arrow here, from normal function until patients develop angina pectoris, there is quite a bit of process. It goes from perfusion abnormality first, and then diastolic dysfunction, and then systolic dysfunction, ECG changes, and then finally patients develop symptoms. So in other words, there is quite a few steps as the plaque grows. And the reason for that is because our coronary circulation doesn't just depend on the epicardial coronary vessels that we can see where all this plaque is formed, but as you can see in my right diagram here, that the flow, the blood flow also dependent on the arterioles as well as the microcapillaries. So if you have this image in your mind that coronary flow happens because of two forces. The first one is what we call hydrostatic pressure. That's the forward flow. And the second component to the coronary flow is determined by what we call microvascular dilation or a sucking pressure. Now, actually, the contribution of the epicardial coronary artery, when I say epicardial, that's the one that where plaque is formed, is actually very little. So what happens is the little guys downstream, whenever there is a blockage, the little guy tries to get bigger, try to dilate, so that the flow is actually not impaired. Studies in dog actually shows only until if the plaque becomes 90% that this mechanism starts failing. But even then, sometimes the body has time to form these collaterals to allow the coronary circulation to remain intact. That's why when they are at rest, things are okay because the heart doesn't have to work harder. But when they're on exertion, that's when this mechanism starts failing if you have significant blockage. So this is the traditional view of how we understand coronary plaque. However, in the last probably 10 years also, more and more studies starts unveiling that the plaque is actually quite a dynamic plaque. Now, these are the cross-sectional artery that is taken, unfortunately, from someone that died because of heart attack. And what the pathologists have identified is there are at least 3 plaque substrate that leads to acute coronary syndrome. The first mechanism is plaque rupture. So this is on the very left-hand panel. As you can see in this coronary section, there is quite a lot of necrotic core. This is the plaque that has lots and lots and lots of lipid, lots and lots of cholesterol crystals. The fibrous cap is thin, And when there is a defect or fissure, then what happens is blood, it gets exposed to the bloodstream, which, as you know, our body, when, if you have a cut outside of your body, the body tries to form clot in order to stop the bleeding. Now, it doesn't really matter when it happens outside, but when it happens in a coronary vessel that is only 2 to 3 millimeter, heart attack ensues. So this is the mechanism that happens to 70 to 75% of heart attack. The second mechanism on the middle panel is what we call plaque erosion. You see the THI here is a thrombus. You can see there is a lot of lipid plaque again, but there is not so much endothelium and there is no fissuring or plaque rupture. This contributes to about 20 to 25%, predominantly occurs in female. And then the last plaque is what we call calcific nodule, typically occurs in elderly population. Now, these are very complicated slides, but basically, as you can see, that the mechanism that leads to heart attack, the hallmark is what we call atherothrombosis, not simply a narrowing of the coronary disease. It's actually the atherothrombosis. That's when the plaque transforms from stable plaque to become unstable plaque. And it requires quite a number of mechanisms to occur. There are several key pathogenetic factors here, several key cellular components as well as triggers. And when they're combined, that becomes the perfect storm. Now, in the last 10 years also, we begin to understand that the major plaque components that actually leads into plaque rupture, etc., is this guy here called thin cap fibroatheroma, or we call this one a vulnerable plaque. As you can see, again, there is a large necrotic core, and you can appreciate FC for fibrous cap is actually quite thin. Now, strangely though, they don't necessarily need to have a significant narrowing. So in fact, some intracoronary ultrasound study have revealed that a lot of the plaque that actually leads to heart attack is not the 80–90% stenosis plaque, but rather the 30–40%, but because they are, but their plaque characteristic has a number of key signatures. They have thin fibrous cap, they have large necrotic core, they have large enlarge of inflammatory cells, they have reduced smooth muscle cells, they have a lot of remodeling, and all this nasty stuff that makes this plaque to be vulnerable to rupture and resulting in atherothrombosis. So, you know, over the next few years, there will be more and more research targeted on identifying this early, because if we can treat this early, then we can prevent heart attack. But watch this space for the time being. So I want to begin with this first spectrum of coronary artery disease, which is someone that has asymptomatic coronary disease. Now, in this group of patients, our objective as medical doctors is twofold. The first one is to assess prognosis and risk stratification. Now, there are several risk scoring systems that has been developed to target this individual. Remember, the term here is asymptomatic, and there is Framingham risk score, there is SCORE, there is the National Heart Foundation score that you and I are quite familiar, which is actually a modified version of Framingham risk, as well as the ASCVD score. So we cannot use this score in someone that is symptomatic. We can only use this score in someone that is asymptomatic in order to predict what is the likelihood of these patients to develop acute cardiac events such as myocardial infarction, you know, death related to cardiovascular disease, unstable angina, you know, etc., etc. So once again, the goal of asymptomatic coronary disease, in assessment of asymptomatic coronary disease, is to assess prognosis and risk stratification. Now, there are a few things that we can do in order to make the process even more robust and put more confidence to all this traditional risk scoring system, because as you appreciate, all this traditional risk scoring system is mainly dependent on age, sex, risk factors, etc. So sometimes when you want to apply that in someone that is 80, for instance, it can be quite confusing, because by the time you're 80, you get all these sorts of things going on. So we can rely on family history, high sensitive CRP, coronary artery calcium score, and ankle brachial index. But essentially, all this added component, the purpose is one thing. That is to identify atherosclerotic burden within someone's heart. Now, why is it important for us to understand or quantify someone's plaque burden? Well, these are the two studies that had been done before, called Prospect in 2011 and then Prediction in 2012. So what these studies have done is they look into patients with minor coronary disease. Okay, they don't look into patients with major. They run the intracoronary ultrasound imaging on the artery with minor coronary disease, and then they follow the patients over time to determine whether this artery contains a plaque or any certain signatures that make the arteries prone to develop heart attack. And as you can appreciate here, is that if the vessel contains thin cap fiber atheroma, then that patient is likely to develop heart attack or unstable angina within that coronary segment compared to those that don't have thin cap fiber atheroma. However, when you combine thin cap fiber atheroma and plaque burden, as you can see, suddenly the risk of that patient to develop some sort of plaque-related event within that coronary artery jumps by about 4 times. And we can see this study that was done a year later seems to be sort of running with the same thing, that if you have a plaque within your coronary artery and that plaque has a large plaque burden, then that particular plaque is more likely to develop coronary event. And again, this is another study looking into 9 or 10 combined study. And it does demonstrate that any baseline plaque burden is associated with 1.32-fold increase in MACE. So therefore, if we can identify this plaque beforehand, that will be very useful. Is there any way we can do that? Well, the answer is we do have imaging modality to do that, and that is the CT coronary calcium score. So once again, I want to make a point clear here. CT coronary calcium score should be used only in asymptomatic patients for risk stratification assessment. You don't do CT coronary calcium score as a standalone test for patients with chest pain unless you're completely certain that the calcium score is going to be 0. Okay, why is that? Because what is CT calcium score? So CT calcium score is a non-contrast CT chest. It is fairly easy to perform as long as you have the right computer software. It doesn't involve any injection of contrast, and it's pretty semi-automated version. So as you can see, it just spits out a number. In left main is 0, RCF 474, etc. Now, why is coronary calcium score is important? Well, let's have a look at this graph. This is looking at coronary calcium score, whether it actually adds value to traditional risk factor assessment. So on the y-axis here is the event rate per 1,000 person years, and on the x-axis here is the number of risk factors, from 0 risk factors all the way to 3 risk factors. And then this line here denotes different quartiles of calcium score from 0, 1 to 100, 101 to 300, and then calcium score greater than 300. So you can see here that the higher the calcium score, the higher the risk of that patient to develop event rate, just as the risk also increases with increasing number of risk factors. But have a look at this bar here. So if you have 0 risk factors, but your coronary calcium score is more than 300, your risk of developing event is higher than those that have 3 risk factors, but they have calcium score of 0. So that tells that calcium score is actually have additional value to traditional risk factors assessment. Now, furthermore, we can also have a look here that not only the value is important, but the number of vessels that contain calcium is also just important. So for instance, if you look into the left panel here, this is the patients where the calcium score is between 11 to 100, whereas the right-hand panel is those with calcium score above 100. And you can appreciate here that the more vessel contains calcium score, the worse outcome the patient is going to be. And obviously, the higher the calcium score, the likelihood of event just gets higher and higher. And one thing that I want to highlight here is the left main here. So anyone that has had calcium score in 3 vessels and left main, their outcome is going to be worse. And therefore, in this group of patients, we need to even aggressively manage their risk factors. So what is the conclusion here in terms of coronary calcium score? It is a useful added risk assessment tool on asymptomatic patients. So once again, you don't do calcium score on patients with symptoms. And another thing is you don't do calcium score as a surveillance method. Because if you have discovered plaque before and then you put someone on statin actually transform the way statin actually protects the patients is because the reason why statin actually helps to modify disease is because statin transforms lipid-rich plaque into calcified plaque. And therefore, if you put someone on statin and you do a calcium score as a surveillance, more likely that calcium score is going to grow even further, but not necessarily because they have a lot of plaque, simply because the plaque has transformed into calcified plaque. So I suggest when you do calcium score, you just do once, and that is for asymptomatic patient. And a patient with coronary calcium score of 0 is very unlikely to have a significant stenosis. That is less than 1% in 3 series, and very unlikely to have a heart attack, which is less than 1% per annum for 15 years. Now, I don't know about you, but I think that is a pretty compelling argument to tell a patient who comes and have calcium score and say, look, you know what, at least for the next 15 years, your risk is less than 1% per annum. Patient goes home happy. So this test is suitable test for someone that is seeking for assessment of their risk on top of the traditional risk factors. Now, I probably would not do calcium score on someone that is old, you know, the 70s and above, or 75 rather than above, because most likely they're going to have some sort of plaque. So I probably would not do calcium score as a standalone test. It's a bit different if you do CT coronary angiogram as well. So that's about asymptomatic coronary artery disease. Now, I want to move on to stable chest pain syndrome. I'm going to spend probably the large bulk of my talk here because this is most likely the kind of patients you will encounter in your practice. So again, stable chest pain syndrome, it is a spectrum as well. Just like coronary artery disease is a spectrum, stable chest pain syndrome also is a spectrum. Included in it are those with stable angina, but you're suspecting they have obstructive coronary disease. Ischemic cardiomyopathy, post-ACS patients, or prior revascularization, such as those that have prior CABG or prior PCI. These encompass a stable chest pain syndrome. These days, to make things even more interesting, vasospastic angina, microvascular angina, or those with asymptomatic ischemia. In other words, someone got referred for stress test by the workplace and the stress test is abnormal. This is also asymptomatic ischemia. So as you can see, there is quite a bit of spectrum, and I'm pretty sure you have encountered these patients in your practice before. I won't have time to cover the vasospastic and microvascular angina. There's also a separate lecture on that one. But whereas in the asymptomatic coronary artery disease, your goal is to assess prognosis and risk stratification, the objective in those with stable chest pain syndrome is actually to rule out or rule in obstructive coronary artery disease. And you also want to do risk stratification. Now, in cardiology, there are a lot of risk scoring, and sometimes it can be confusing when to apply it. So it's important to know which spectrum of disease you're applying this risk scoring. So the goal when you want to establish whether someone actually has obstructive coronary disease or not, we need to first assess what is the pretest probability of these patients to contain this disease. And there are a few risk scoring, such as Diamond Forrester, Duke Clinical Score, CAD Consortium. You can download that in the apps. It's widely available, so it's pretty easy. And you, once you establish the pretest probability, then you can choose the right test for the very condition. There is also another risk stratification model called ABC-CHD model that is centered around biochemical measurement. So there are few risk scoring, but essentially some of the key investigation tests that you want to do or apply in this group of patients include ECG, biochemistry, including troponin plus minus BNP, echocardiogram, and chest X-ray. So I'm going to walk you through some of the clinical assessment. First of all, when you assess someone with chest pain, we need to establish whether the chest pain is typical for angina or not. So there are three components to tell that one's chest pain is definite angina or not. So anginal pain is described as constricting discomfort in the front of the chest or in the neck, shoulders, jaws, or arms. That's one component. The second one is they need to be precipitated by physical exertion. And thirdly, they are relieved by rest or GTN within about 5 minutes. So if you have all three, that is defined as typical angina. If you have 2 of 3, it's defined as atypical angina. If you just have one features, that is a non-anginal chest pain. And I do acknowledge sometimes it can be hard to call chest pain non-anginal, but this is the NICE guideline in 2016 that still applied even in various guidelines. So it continues saying, unless clinical suspicion is raised based on other aspects of the history and risk factors, exclude a diagnosis of stable angina if the pain is non-anginal. There are some features that make diagnosis of stable angina unlikely. Things like continuous or very prolonged. You need to think whether this is actually non-cardiac chest pain or it could be acute coronary syndrome. Unrelated to activity, brought on by breathing, associated with symptoms such as dizziness, palpitations, tingling, or difficulty swallowing. So that's how you differentiate between whether an angina is stable, or we're going to have a look at the unstable angina a bit later on. Now, I want to come back again to the assessment of pretest probability. Why is this important? Now, this is actually a graph that is taken from ESC guideline, European Society of Cardiology, from last year. I used a lot of ESC guideline in my talk tonight because they have quite a lot of update recently. Now, as you can see that if you are between 30 to 39 and you are male and you present with typical anginal chest pain, your pretest probability is actually still quite low, okay? But if you're 40 to 49 and you're male and you present with typical anginal pain, your pretest probability is 22%. On the other hand, if you are presenting with non-inguinal chest pain, your pre-test probability is actually only 3%. Now, why do I bring this slide up? Simply because all these tests that we normally order, things like stress test, stress echo, myocardial perfusion scan, things like that, they are actually most beneficial when the pretest probability is greater than 15%. When the pretest probability is between 5 to 15%, then you need to utilize a little bit of clinical information to make the test useful to either establish a diagnosis or rule out a diagnosis. Now, when the pretest probability is very low, i.e. less than 5%, then sometimes my recommendation is actually not to do any test unless you're very convinced that you're going to find something. The reason why is because, I give you an example. You have someone in their 20s and they, in fact, I probably wouldn't do that because we're probably going to cover that in our clinical scenario later on. But if the pretest probability is too low, then there is a likelihood that the test is going to return a false positive test and leads patient down all the unnecessary tests that can be sort of more dangerous to the patient and end up with providing a low value base care rather than high quality care. Now, there are two forms of non-invasive testing. I deliberately don't put coronary angiogram, but even coronary angiogram, they also have anatomical and functional testing as well. But there are pros and cons with both tests. So for instance, for anatomical test, the benefit is it allows us to assess subclinical disease and detailed plaque characteristics. That's what CT coronary angiogram do. Whereas stress tests can only give us a binary outcome that is normal versus abnormal. In CT coronary angiogram, at least, that allows us to detect, early plaque with high-risk features such as lipid-rich plaque or remodeling, et cetera, et cetera. So that's the benefit of anatomical tests. It is also highly sensitive with high negative predictive value. So CT coronary angiogram, for example, the negative predictive value is basically 100%, 99 to 100%. If your CT coronary angiogram showed normal coronary arteries, you don't have coronary artery disease, full stop. You might have microvascular disease, but you definitely don't have atherosclerotic coronary artery disease. The problem with anatomical based tests is there is a challenge when assessing borderline lesion, and especially calcium or previous stent can be quite an enemy for us to actually assess lumen stenosis with high degree of accuracy. Functional tests, on the other hand, allows us to measure exercise capacity. We can assess whether the symptoms is reproducible. We can assess burden of ischemia, but it can be normal and extensive but non-critical disease. Now, I've listed on the table here the sensitivity and specificity of various tests. Now, just for a refresher, a test that is sensitivity is useful to rule out a condition, whereas the specificity is useful to rule in a condition, right? So there is never a perfect test. There is always a trade-off between each test. That's why I always tell my patients the best test that is available is called post-mortem test, but they're always a day late. So as long as you are a living specimen, there is always some degree of limitation, and it is up to us as medical doctors to understand various strengths and limitations so we can order the right test. As you can see, once again, coronary CT is very sensitive, but the specificity, it varies dependent on various factors. So what is it for us as cardiologists that we tend to try to look at a patient to determine that, I'm not happy with this patient, or actually you're fine? So there are a few things. We are interested in looking at ejection fraction, because it is part of the prognostic key factors, exercise capacity, extent of ischemia, so it can be derived from ECG or imaging or perfusion. We want to understand how many coronary vessels involved, because as I have demonstrated before, the more arteries involved, the worse someone's risk is. And then we also want to identify the stenotic side, because imagine coronary tree is like a tree. Obviously, if the disease happens on the trunk itself, if the tree got chopped off at the trunk, then it means the whole tree gone. However, if the disease is located on the twig of the branch, then even if it's gone, it's not going to impact on the heart damage in a substantial fashion. So that is really the analogy of why stenotic side is actually very important. Now, I want to walk you through some of the previous data to demonstrate my point. So let's have a look at the impact of ejection fraction on survival. So there are 4 panels of graph from panel A, B, C, D. So as you can see here, that the solid line represents those with ejection fraction above 50%. The second line represents those with ejection fraction between 35 to 49. And then the dotted line here represent those with ejection fraction less than 35%. So this is for all comers. And as you can see, the lower the ejection fraction, the lower the survival rate. Now, this graph here is in those with single vessel disease. This one is in double vessel disease. And this is for triple vessel disease. And as you can see, that if you have triple vessel disease with ejection fraction above 50%, then your survival rate in 14 years is about 58%. That is compared to if you have single vessel disease, your survival rate is still 80%. But if you have poor ejection fraction and you have triple vessel disease, your survival rate in 14 years is literally only 10%. So therefore, ejection fraction is important, and survival decreased according to LV ejection fraction and the number of obstructed vessels. That's why ejection fraction is one key component to pay attention when we assess someone with stable chest pain syndrome. What about exercise capacity? Well, they are just as important. So let's have a look at this graph on the left panel here. This is again all comers, and this is in those patients that are known to have at least one significant coronary artery disease. And as you can appreciate here, their survival, if they can only exercise up to stage 1, is actually very poor when compared to those that can exercise up to stage 4, which is roughly about above and beyond 12 minutes. So the longer someone can exercise, the better it is for them. And as you can see here again on the graph here, that again, this is adjusted heart rate for mortality. And you can see that this orange represents those that can only exercise less than 6 minutes. And as the patients have greater exercise capacity, you can see that they have more favorable outcome from the point of view of mortality. With regards to the likelihood of developing myocardial infarction, it's a little bit of a mixed zone. It's more useful in those that have previous PCI, but certainly in terms of death, every 1 minute increment in exercise capacity is associated with 13% reduction in mortality. So therefore, exercise capacity is very important. That's why for me personally, if I am referred someone for stress tests, I try as much as possible to exercise them rather than give them medication, because of this very data that allows us to give patients a bit more prognostic information. Now, this is another interesting data. How about if you have triple vessel disease, but you have good exercise capacity? Well, let's have a look at it. So you can see here, this is the group of patients that can only exercise for not even stage 1. So they can only exercise for about a minute or two, but they have to stop because they have symptoms. And this is those that complete stage 1. This is complete with stage 2 and 4. And this is that complete up to stage 5. This is like the high performers. So you can see that even if you have triple vessel disease, obviously with a relatively intake ejection fraction, if you can exercise, for a long time on the treadmill, that is by stress test, your survival rate in 4 years is 100%. But if you can only exercise for very short duration, your survival rate is only about 53% by 4 years. So exercise capacity is just as important. But that's not all the story. We can see here that if we combine exercise capacity and the extent of ST deviation, that is also prognostic. So panel A represents those with less than 1 millimeter ST depression on exercise. B is over 1 millimeter, and this is actually 2 millimeter or above. And you can see just from the eyeballing it, this is the exercise stage, that let's say here, this one, you can appreciate that this is those with very abnormal ECG with exercise. But if you can exercise for good duration, your outcome is still reasonable in 5 years and pretty much comparable to those that only has less than 1 millimeter ST depression, but they can only exercise for short duration. So exercise capacity, extent of ST deviation, it has significant impact whether someone is going to die because of their cardiovascular disease or not. So now, having understood all those things, what are the options of non-invasive imagings that are currently available? I just want to give you a bit of a brief snapshot here. So myocardial perfusion scan has been around for a very long time. Now, the form of stress test can be done either by exercise or vasodilator, such as using perhexylene. It involves injection of radioactive tracer. In some lab, they use technetium. In the other lab, they can use sestamebe, etc. So under this group, the most common one is SPECT MPS, as well as PET imaging. You know what? It's very few centers that have PET imaging because they are expensive, but it is another thing that is of interest to many cardiologists because it provides myocardial blood flow. What do we do in myocardial perfusion scan? We assess perfusion. Again, we assess LV ejection fraction. We assess their ECG, symptoms, and exercise capacity. All the key prognostic factors that I've already mentioned. So this is the prognostic value of MPS. Similar story here. As the ejection fraction declines, so is the cardiac death increases. Similar stories that I've already identified why ejection fraction is important. Now, on the right-hand panel here, it also on the x-axis here, they have no ischemia, mild to moderate ischemia, and then large ischemia. And as you can see, there is a difference between those with ejection fraction greater than 50% versus those with ejection fraction that is less than 50%. What you can appreciate here, if you have poor ejection fraction and no ischemia, your risk is still higher. Now, if you have large ischemia, you can see your risk of death essentially doubled if you have both poor ejection fraction and large ischemia. And this is just to demonstrate that ischemia is also another prognostic values. So this is what MPS does. What about stress echocardiography? Well, we do it all the time here. We have the exercise form and the debutamin form. What do we do? Again, assess ejection fraction. wall motion abnormalities, we can assess the stress diastolic function only in EST. So sometimes we have patients with shortness of breath. We can't really tell whether their symptoms is cardiac or not. Sometimes we do diastology as well, where we can see whether patients has impaired diastolic function with exercise, if patient has exercise-induced pulmonary hypertension. That just gives us extra information that can explain why a patient is actually short of breath or not. We can also assess ECG, exercise capacity, aortic stenosis severity with dobutamine stress echocardiogram, and myocardial viability. Now, I need to mention that dobutamine is not necessarily a safe drug, because if you have glaucoma, I would caution ordering dobutamine stress echo, simply because in dobutamine stress echo, sometimes we inject atropine, and atropine is contraindicated in patients with glaucoma. And some people can have adverse drug reaction to dobutamine. So, you know, whenever you administer medication, there's always a potential side effect. And if the window is not good, we might need to use contrast to improve the endocardial definition. Similar line of stories, the prognostic value of stress echo. So this is the wall motion severity index. Obviously, the higher, the worse it becomes. And you can see the cardiac event rate in 1 year, if you don't have wall motion abnormality, but you have established coronary disease, your risk of death is still less than 1%, but the higher the ischemic zone, the higher your risk of death. And again, this is a similar story that I've presented before, that if you have poor ejection fraction, you know, the risk will be multiplied. So over here, this is a patient with normal ejection fraction. This is impaired, you know, so if you don't have ischemia, but you have poor ejection fraction, then your risk essentially 5 times higher. And the story goes on and on. So you can see that there is a theme going on here. What about stress MRI? I won't touch too long because we don't have it here anyway. But in MRI, obviously, there is no stress component. There's only medication component, and you can do adenosine perfusion or dobutamine, and you can assess a number of things as well. And finally is a CT coronary angiogram. So CT coronary angiogram is essentially the only non-invasive anatomical based testing. So normally following calcium score acquisition, IV contrast is injected. So that's how different CT coronary angiogram and calcium score. One doesn't involve injection of contrast, the other one involves injection of contrast. In order for CT scan to have good picture, patients needs to have low heart rate, ideally less than 60, because ultimately you try to acquire CT on a moving object, just like trying to take a picture when someone is running. You know, unless you have a very powerful camera, the image quality is going to be blurry and causing lots of artifact. So if you have a patient that has AF, non-controlled, and patient has a lot of ectopics, CTCA is not the right test to assess coronary artery disease. We often need to pre-treat patients with beta blocker, plus minus ivabradine, and GTN to dilate coronary vessels. So again, I've mentioned this before, CT angiogram has excellent negative predictive value, and the stenosis is graded as absence, which is 0%. Minimal is less than 25%. So when you look into the result of the CTCA, don't get hung up on the number, but rather just try to make that number into descriptive term, okay? Because CT is different to coronary angiogram, where angiogram is luminogram, CT is evaluation of vessel. So absence is 0%, less than 25% is what we call minimal stenosis, 25 to 49% is what we call minor or mild stenosis, 50 to 69 is moderate stenosis, and severe is 70 to 99, and included is 100%, okay? And I've already mentioned the benefit of the CT. It allows us to assess plaque characteristics, stenosis severity, cardiac morphology, some extracardiac manifestation. We often find patients with hiatus hernia that is causing their chest pain. And also, it can assess ischemia, but it is actually very controversial, and it's better be, I mentioned that there, but you can ignore it for the time being. So again, CTCA is a powerful prognostic value. So on the left-hand panel is those with moderate plaque, and on the right hand is those with severe plaque. You can see the greater the more the number of vessels involved, the worse the outcome. But if you have left main plaque, your outcome significantly worse by 15%. And if you have severe plaque in one vessel, is better than if you have severe plaque in multiple vessels. And once again, if you have left main plaque, that is a bad outcome as well. So this is why that's why CTCA has prognostic value, and that is important. Now I've summarized some of the possibility of high event risk, and I'll leave it up to, I will leave this with you so you can actually peruse it. So anyone with area of ischemia more than 10% on SPECT or PET perfusion imaging, they are considered high event risk. If you have more than, if you have 3 or more wall motion abnormality upon stress, you also belong to high risk. So these are some features of high event risk that would prompt us as cardiologists to investigate this further, perhaps with coronary angiography to prognosticate the disease even more. Now, these are the summaries of strength and limitation of each test. As I mentioned in the beginning, there is no perfect test. I mean, look at this. This is myocardial perfusion scan. A lot of data, it's widely available, but look at the radiation, 10 to 20 millisievert. Compare that to CTCA. What a big difference. So, when you want to order the MPS every year, think again, because ultimately you're exposing patients to all these high radiation dose, and that's why I can understand why the MBS item number now only allows claim for 2 years for stress test. Stress echo, on the other hand, no radiation, low cost, but it's operator dependent and poor windows. So if you have patients who are obese, for instance, we need to interpret the test with caution, and those are some of the limitations that I have highlighted before. Now, I want to touch briefly on the management of chronic coronary syndrome. So ESC actually has renamed stable angina to become chronic coronary syndrome because essentially it is a spectrum, as what I've highlighted before. So the management of CCS actually is a combined management of aggressive lifestyle modification, optimal medical therapy, and revascularization. Now, as an interventional cardiologist, I must say it is a in a sense, it's quite interesting because I seem to be going against my own specialty. But in stable chest pain syndrome, revascularization has not been shown to significantly alter someone's prognosis when compared to optimal medical therapy, except in the case of left main disease or triple vessel disease with impaired ejection fraction. So I just want to make that important. Maybe if you have proximal LAD, we'll see, but this is actually according to the data. This year, this trial, Ischemia, was published and sent a shockwave in the cardiology community, especially for the interventional cardiologists. Remember, we're not talking about ACS, we're talking about stable coronary syndrome. So conservative is those that just being put on medical therapy. Invasive strategy is those that undergo coronary angiography with the view to do revascularization. With primary composite outcome of cardiovascular related death myocardial infarction, unstable angina hospitalization, heart failure, and resuscitated cardiac arrest. No difference between those that undergo invasive strategy versus conservative strategy. If you look into death from cardiovascular causes or myocardial infarction, no difference. What about death from any cause? The graph doesn't even separate. What about prevention of MI? No difference. So interestingly though, the population of patients that are excluded in this study are those that have documented left main disease on CT coronary angiography. So if you have CT coronary angiography, all these patients, actually nearly all of them, undergo CTCA before randomization. And if they have 50% left main disease, they're ruled out of this study. So that's why left main, once again, it's prognostically important. But anyone else that have single vessel disease, if they only have stable chest pain syndrome, just remember this trial. No difference. Obviously, we can dissect this trial even more. But why do I actually bring up these slides? Because that opens up an opportunity for general practitioners to be involved actively in the management of coronary artery disease. Now we have so many medical therapy that wasn't present, 20 years ago. And sometimes there is a knee-jerk reaction, especially by us interventional cardiologists, that if there's blockage, we have to stent it. But these trials and some other trials have shown that maybe we don't need to be that aggressive and we can continue to treat patients with optimal medical therapy. So these are just some of the suggestions, follow-up that we can do. Cardiovascular care, give a visit, can be cardiologists, internists, general practitioners, or cardiovascular nurse. So the red one is the red circle is time for decision making on optional dual antiplatelet or antithrombotic therapy. Yellow is time for decision making on dual antiplatelet therapy continuation in patients with PCI, and this is the advisable time point. You can see at baseline, we need to assess symptoms, do risk scoring, stratification, and resting ECG. No need follow-up in 3 months. In 6 months, if the patient has PCI, that's the first time point check to determine whether we can stop the dual antiplatelet or not. And when you see the patient, you do risk scoring, stratification. In other words, you want to ask what is the lipid level, the HbA1c, the sugar, the blood pressure, and then you do resting ECG. And then at 12 months, the same thing too. What about post ACS, those that is after 1 year? Again, no need review in 3 months or 6 months. You just need 12-month review, and then you do risk scoring as well as the resting ECG. You can choose to see them even more frequently, but I'm just saying these are just some of the suggested follow-up guideline that we can do. In other words, whenever we see patients, even more we need to pay attention to their risk. So for instance, if someone has chest pain and the patient smokes a lot, their lipid is favorable and their blood pressure favorable, then their treatment is actually not for angiogram necessarily. Obviously, if they are high risk, yes, but their treatment is really stop smoking. That's the way to alter their prognosis. If their blood pressure is the one that is poorly controlled, then we need to be a bit more obsessive with the blood pressure control. So these are some suggestions with regards to echocardiogram, stress tests. You can see here that it's good to do an echocardiogram at baseline as a reference, and then at 1 year if previously abnormal, or every 3 to 5 years to evaluate all these things if patient is stable. What about stress tests? Does patient need annual stress tests? Well, if the patient is asymptomatic, not really, because this guideline says as necessary to investigate changes in symptoms level and or early after revascularization. So it's not unreasonable to do stress test after revascularization. But if the patient is stable, every 3 to 5 years is more than enough. And this is, obviously a patient is unstable, then you need an invasive coronary angiogram. So finally, we get to the last disease spectrum, hopefully not for long, which is on ACS, which is probably will need a dedicated and separate topic on its own. But just want to touch base again, there is a spectrum of ACS: STEMI, non-STEMI, unstable angina. MINOCA stands for myocardial infarction with non-obstructive coronary arteries. SCAD stands for spontaneous coronary artery dissection. Now, the objective in ACS, in contrast to stable chest pain and asymptomatic coronary disease, is actually to establish rapid diagnosis and early risk stratification. Is there any risk scoring system for that? Yes, there is. TIMI risk score and GRACE score. I actually prefer GRACE risk score because that helps me to whether to admit patients or discharge. And the key investigation here is ECG, troponin, especially high sensitivity troponin, echocardiogram, and coronary angiogram. So these just the diagram represents the diagnostic and triage algorithm from the low likelihood of ACS to high likelihood of ACS. The right-hand side here is obviously cardiac arrest. And you can see if a patient has a very localized chest pain where they can pinpoint with one finger, the likelihood for ACS, especially if the ECG is normal and troponin level is normal, is very low. And you're perfectly within reason to rule out MI or possible call it, doing it as an outpatient. Obviously, the more we progress to the right-hand side, the more likely we are ruling in MI. So I just want to touch base a little bit surrounding the high sensitivity troponin assay, which I think is going to be very useful. It is already very useful. I used to dislike troponin, but now I am a fan of troponin simply because it allows us to make a quick diagnosis, to rule in or rule out algorithm. Remember, this only applies for those with hemodynamically stable but suspected to have non-ST elevation acute coronary syndrome. Essentially, the first gate is ECG. If you have STEMI, they go into different path, but if you have non-ST elevation acute coronary syndrome, troponin is your friend. So if someone has suspected non-ST elevation ACS, presents with very low troponin or low troponin, and the delta change in 1 hour is not that significant, you essentially rule out myocardial infarction, okay? Simply because the risk of this patient to develop myocardial infarction in 30 days is somewhere in the region of 0.3 to 0.2%, so extremely low. You can rule out and discharge, and you can decide whether to do a stress test, CCTA, or angiogram. However, if you have high baseline drop or delta change that is significant, you can also rule in a patient. And you can see those that are uncertain, you can do an extra trop or echocardiogram to risk stratify these patients further. So not all chest pain comes to the hospital requires a coronary angiogram. No, we have now a powerful tool in order to help us to risk stratify this further. Now, these are some of the cutoff assays, so it's important for you to familiarize with your assay. So over here in Rockhampton Hospital, we have this Beckman-Coulter. So the very low is less than 4, which means it's almost undetectable. Low is less than 5, and significant delta change is less than 4, whereas high is greater or equal than 50. and 1 hour change is greater or equal than 15. In other words, if a patient comes in with chest pain and their troponin is 3 and repeat at 1 hour or 2 hours is still 3, you can rule out MI according to this algorithm. Or if you have patients with troponin of 4, which doesn't belong to this, and the change in and then it goes up to 7, for instance, which is less than 4 elevation, you can also rule out MI. So we can see that you can use troponin to actually help you making early decision. Otherwise, we end up admitting every patient to the hospital for inpatient test. Look, in the interest of time, I probably will skip. I have few picture of, what stress echo look like, angiogram, etc. I'm just going to skip this in the interest of time. Sorry there. So I just want to summarize some of the points that we have spoken about tonight. So first of all, coronary disease is a clinical spectrum ranging from asymptomatic to unstable disease. And our assessment is focused not just on diagnosing, but risk stratification. What I'm trying to say here is if you have done tests and the patient is low risk according to all the tests, and the patient still continues to have chest pain, we need to be able to tell them that this is a non-cardiac chest pain. Because otherwise, patient may have angiogram every 12 months and patient might still have chest pain. So it's important that we need to be able to draw a line somehow, some way along the line. Obviously, if there is a suspicion of microvascular angina or vasospastic angina, then we need to make an exception to that one. But remember, those that have vasospastic angina or microvascular angina, they will still have some sort of anginal symptoms, whether it's atypical angina, which is 2 out of 3 criteria, or typical angina. That is important for them to be classified as one of these 2 diseases. No perfect test. I hope through tonight's lecture, it at least increase your awareness of the strength and limitation of various imaging tests. And we have gone through some of the key prognostic factors. And remember, comprehensive management of coronary disease involves monitoring, lifestyle modification, optimal medical therapy, and revascularization. We have covered a bit about high sensitivity troponin in ACS management. And when in doubt, we need to use our clinical judgment. Thanks very much. That's my contact. I deliberately put my mobile, but we don't have 24-hour on-call here, but happy to be contacted if you have any quick question. Thanks very much. Back to you, Bhavesh.
Great. Thanks, Sam. So appreciate that. It's good to see that you're keen to give your mobile number. Hope you're not going to get so many phone calls. No, we have a questions from the colleague that what is the repeat troponin timing? Is it 3 hours, 6 hours? So when patients present with the chest pain in ED, what is a timeline they follow in the ED?
Yeah, so thanks for that question. It really depends on the assay that you have. So if you don't have the high sensitive troponin, then I suggest to follow the ACS pathway according to statewide Queensland pathway, which is basically 2 hour, 3 hour troponin. But if you have high sensitive troponin, in Queensland, we still adopt the 2 hour pathway, which actually, if you look into my slide, the slide actually divides into 1 hour and 2 hours. So you just adopt that. Yeah, but in short, in Queensland, we still use 2 hours.
Great, thank you. So here in the Rocky Hospital, the ED department, because I worked there, so they do a 2 hour troponin there, and if it's a troponin positive or have a significant raise, they can do the third troponin, or they can involve the cardiologist for their opinion. If it's a first troponin, it's clear-cut positive, and there is no any other factors that can raise the high troponin, like a renal failures or other, like a pneumonias or other factors, then that's definitely it's coming from the cardiac until prove otherwise.
Mm-hmm.
So it was quite informative sessions, and thank you very much. Let's start with the case-based scenario. So as a GP, we get it a lot of patients, they have a different concerns for a different reason. So I try to include some of the common presentations we see in a GP clinic. So let's start with the first scenario. That's 45-year-old male from Asian background. That person is concerned about the heart attack. So when you ask the history that he's a non-smoker, he's generally quite fit, play a lot of sports, you check that person's blood pressure, that blood pressure is normal, pulse rate is normal, the BMI is normal. Then you further evaluate, and then you find out that his father had AMI at the age of 50 and had a sudden death with AMI. And his mother had a MI in the 60s. And just a second, I'll just get it in my slide. Oops. So you organized some blood tests for him, and his full blood count, LFTs come back normal. You also did a HbA1c to just a one-off to rule out any risk factor of diabetes. That's come back fine. The cholesterols come back slightly elevated, but because that the risk for this person is low, that's still considered as a normal. So total cholesterols come to 5.2, triglyceride is normal, HDL is come up in a bit lower to 0.8, and LDLs come to 3. You did an ECG also, and it came back normal. So now this is a 45-year-old male, no risk factors. Like examinations is quite unremarkable, and bloods are not too bad, and we just need to rule out the coronary artery disease in this patients. Back to you, Sam.
So basically over here we have someone, I guess, I'm still trying to get used to this kind of online interactive. I'm kind of more used to the lecture situation, but over here in the scenarios, we can clearly see already that the patient is actually asymptomatic, and the patient doesn't have much in the way of cardiac risk factors. If you apply any traditional risk scoring for asymptomatic patient, it will pop up as low in this context. I would estimate probably his ASCVD score is somewhere in the region of 2 or 3% in the next 10 years on the basis of the cholesterol alone. Having said that, the patient has strongly positive family history of ischemic heart disease. So positive family history is defined as first-degree male relative suffers from cardiovascular event at the age of less than 55, and for female, less than 65. So if a patient actually has heart attack at the age of 60 and they are male, you cannot blame the gene. Okay, so that doesn't constitute as positive family history. Furthermore, the patient actually has a cousin that died suddenly at the age of 40. So clearly this man is very concerned and they want to understand the cardiac risk. Now, because the spectrum of this patient is asymptomatic cardiovascular disease, so the best test for this patient is calcium score. Okay, that would help to prognosticate this further, because in this patient, if the calcium score is 0, you can tell them, look, your risk of developing coronary event is less than 1% per annum over the next 15 years. The other test that I would perform in this man is actually an echocardiogram, just making sure that the patient doesn't have any evidence of structural or functional cardiac abnormality, because who knows, the cousin might die because of cardiomyopathy or might die because of underlying hypertrophic cardiomyopathy, etc. So once you establish the two, then you can just reassure the patients and continue to monitor his cholesterol profile, and then you can revert back using the traditional risk factor to determine when to start statin or not. Although if the calcium score is 0, there is probably little role for statin therapy in this context.
So with this same patient, if calcium score come back like above 100, how do you manage that risk factors? Do you aggressively bring the cholesterol down in this patient?
Absolutely. If a patient has elevated calcium score, that means the patient has established coronary disease, but they are asymptomatic, which means that we need to aggressively manage the risk factors by trying to bring the cholesterol profile, especially the LDL, to be less than 1.8. That would be one thing that I would do in this patient. If you want to risk stratify the patient further, you can consider doing a stress test to see if patient has, flow limiting disease. But if you want to but what I'm trying to say is whether a patient has stress test or not is not going to change my decision in starting the patient on statin therapy.
Very good. Thank you. Let's move on to, if any colleagues has any questions, feel free to just put the questions in a chat box. We will discuss as we go. Let's move on to the second scenario. So second scenario is 60-year-old male Caucasian truck driver with a background history of hypertension, diabetes, and dyslipidemia. He's complaining of the chest tightness when especially he goes for walking around 1 kilometers in the distance, and the chest pain gets better with rest. When you ask about the smoking, as usual, he said that not as before, and when you figure it out further, he has on average 20 cigarettes per day for the last 40 years. On a further assessment, his blood pressure is slightly elevated, pulse rate is fine, his BMI is a bit elevated with the weight of 104 kilograms. He has no family history of heart attack. When you do his routine blood test as a part of your routine care and care plan, his diabetes HbA1c come to a little bit suboptimal to 7.4. His cholesterol result is 5.2. His triglyceride is a little bit elevated to 2.4. His HDL is normal, and LDL is at 3. You did your ECG also on these patients, and the resting ECG come back normal. So in this patient who is having a angina symptoms with the exertions with the multiple risk factors, so we would like to know that how we proceed for the coronary artery disease rule out in this patient, please.
All right, so in contrast to the patients that we had before, clearly this man has high risk factors from the point of view of traditional risk factors. Now, remember, can we apply, a Framingham or things like that? Not in this context, isn't it? Because in this context, the goal has shifted from just risk estimation to rule in or rule out obstructive coronary artery disease. Now, this patient is diabetic and smoker, so most likely he already has had underlying coronary artery disease. Furthermore, he is 60, which is beyond 55 when coronary disease tends to start forming in male. So we can consider a CT coronary angiogram in this context to find out if there is any significant obstructive disease, in particular to rule out left main condition. That's one option. Having said that, in this context, I probably might start with a functional test, such as a stress imaging, either stress myocardial perfusion scan or stress echocardiogram. The reason being is, remember, with CT coronary angiogram, if patient has calcium or lots and lots of plaque, CT is not very smart in differentiating between severe and moderate disease. So sometimes you need to have stress tests in order to do a few things. First of all, the benefit of stress test in this man is we can assess his functional exercise capacity, right? We can also assess whether we can reproduce his symptoms by stressing his heart. And then thirdly, we can assess for ECG changes, and if there is any imaging changes indicative the extent of ischemia. So that's one of the benefits of doing stress tests in this man. The second benefit of doing stress tests in this man is because the patient is a truck driver. And as you know, as a truck driver, we need to be able to clear him to go back to driving a truck. And the clearance for heavy vehicle license is quite regimented, which includes assessment of ejection fraction, again, just like what we have already spoken about, including assessment of exercise capacity, and to ensure that the patient doesn't have ischemia. So yes, CTCA is one possibility, and but in this context, I think stress imaging is more useful to risk stratify this in view of the clinical scenario. He also needs an echocardiogram because, as I said, we need to assess the ejection fraction to ensure that the patient doesn't have any underlying structural or functional cardiac abnormality. But that's how I would approach. What I would not do in this man is to go straight to coronary angiogram, okay, on the basis of everything that we have already spoken about.
Right. Thank you, Sam. So just to remind the colleagues that I think the commercial driving license guideline is that if it's anyone's with ejection fractions less than 40, they are not eligible for the commercial driving license. Is that right, Sam?
Yes, correct. Yeah.
Yep. And second thing with the calciums, like a CT coronary angiogram, it's not funded from the referral from GP. It needs to become from the cardiologist.
Correct. Yeah. You know, so if patient actually undergoes CT through referral from GP, they would have to fork out of pocket fee for that.
Yeah. We have a questions from the previous scenario that at what calcium score level that you consider to start statin to reduce the risk factors of dyslipidemia?
Yeah, it is controversial, I must say. Obviously, the calcium score is 0. I would not put them on statin. If you look into some data, the mortality or the event starts turning north once you reach a calcium score of 30 or above. But again, you know, there is no clear defined, you know, we're still arguing and debating about that. So calcium score 0 is extremely important. Anything above that, it's becoming controversial. Probably above 30 is when the statin should start. Between 1 to 30, we probably need to utilize a number of clinical information, such as, you know, if a patient, let's say in this context, has strong family history, I probably would err on the side of caution and start the statin, given the strong family history. But if a patient doesn't have strong family history at all and just slightly elevated cholesterol, I might just hold off and see whether and see how patients go over time. Another test that can be considered, but it's becoming really unpopular, is what I call high sensitive CRP, to risk stratify that further to determine who actually needs a statin or not. But again, it is largely research based, but there are some data that shows if you have elevated high sensitive CRP, then you definitely would derive benefit from statin. So that's how I would sort of split this even more.
Great, thank you. Yeah, that's high sensitive CRP. That's I haven't heard that name before, and I'm not sure the other labs they do it even as a private. I don't think there is Medicare rebate for that. Yeah, it's a good, good to know that some other indicators there.
Yeah, yeah. So it's for risk assessment, but the problem with high sensitivity CRP is that obviously if your patient has underlying inflammatory condition, it will always be elevated. So it needs to be done when patient is well. And again, it should be done on patients that are asymptomatic. I would not do that in, let's say, 70 years old diabetes and things like that, because that's not the focus of our risk prevention, isn't it? The one that is our focus is those in the 40s. That's really the one.
Great. Thank you, Sam. Let's move on to the third scenario. So we have a third one is a 38-year-old indigenous lady. She just presented with the not fit as before. So she just said that she can't do much work without getting like a sort of breath, especially in the last few weeks' time. Today in your room that she's complaining of chest tightness, and also that she's getting a sweatiness and palpitation with the chest tightness. She's been a smoker for the last 30 years, and on average, she's been smoking 20 cigarettes per day. On your assessments, blood pressures come slightly elevated with the BMI come to 82 with the, BMI of 24 and weight of 82. So her father and few uncles had a heart attacks in their 60s. So with the further, she had some blood tests done not long ago, and that her full blood count LFTs were fine. Her diabetes results came back normal. The cholesterol result is total cholesterol is 5.2, triglycerides 1.8, HDL is a little bit on the lower side, and LDL of 3. You did a resting ECG, which came back fine. And when you look at it, this discharge summary that you get it from ED, that's she went to the hospital 6 months ago with the chest pain, and then after her troponin were negatives, and she had a stress test in hospital. So the report suggests that no ischemic changes on ECGs, but suboptimal exercise tolerance, and she started feeling sort of breath with the 4 minutes of exercise. So here she comes with a indigenous lady with the family history, slightly elevated blood pressures and cholesterol result, and with the angina symptoms or acute coronary syndromes. So how do you assess this patient, Sam?
So clearly this patient is highly suspicious of non-ST elevation acute coronary syndrome, isn't it? We do know it is not a STEMI, but as you can see that patient has what I call accelerated angina. So probably this, intermittent shortness of breath that she's been having in the last few weeks is what we call anginal equivalent symptoms. And then she had these very concerning symptoms of chest tightness across the chest. She's sweaty and having palpitation. She has risk factors of smoking, and she's indigenous. As we can see, as we know that indigenous population tends to manifest with coronary disease much, much younger than the average standard population. Now, this patient, interestingly, had stress test, plain treadmill test about 6 months ago when she came with chest pain, but no ischemia. But as you can see, that the patient had poor exercise tolerance. So therefore, if you have followed through the slides, exercise capacity is just as important prognostic indicator. So yes, the stress test didn't show ischemia, but she is not at a low risk. She is at a moderate risk according to the stress test. The reason why we put this case scenario is when you look into the result of stress test, probably try not just to look into one side. So, normally we stop at looking at no ischemia, but we need to look into several other components in order to compute in our minds what is the likelihood risk in this lady. You can apply Duke treadmill score in this context, and you will come across that the Duke treadmill score for this lady, I would imagine, is around moderate risk. Okay, so she's not low risk from the stress test 6 months ago. So in this context, I would definitely send her to the hospital, and she would need to undergo the troponin risk assessment, just like what we spoke about. If the high sensitivity troponin is very low, and the repeat troponin doesn't show any delta change at all, then at least we know that she is not at high risk of immediate heart attack. Then we can investigate this probably as an outpatient basis, early cardiology follow-up, or even early coronary angiogram or any investigation that needs be. But certainly what I would do in this context is I would certainly put her on optimal medical therapy. I would make sure that the patient is on aspirin, ensure the patient on high dose statin. And by the way, high dose statin is only 80 milligrams of atorvastatin or 20 milligrams and 40 milligrams of rosuvastatin. Okay. Other than that, they are either moderate or low intensity statin. I would put her also on anti-anginal medication like beta blockers or possibly isosorbide mononitrate, because what we want to do in this context is really control the symptoms and try to settle it down. And if the patient still has symptoms, very quickly to escalate to dual antiplatelet. So you can see that our response needs to be tailored according to the clinical spectrum. But certainly in this context, we will implement the management of non-ST elevation ACS, which the goal is two things, as I said: rapid diagnosis and early risk stratification.
Great. At what level do you see these patients in an outpatient clinic? So these patients went to hospitals, that troponins come back negative. They did another stress test in AED. They still come back negative with no any ECG changes. And then patients come back to the GP for a follow-up. So you are doing like a medical management and just keeping a risk factors under downs. And if patients become asymptomatic, then you generally, I believe, that don't need any further follow-up. But if a still patient is symptomatic, do you like to see in an outpatient clinic?
Yeah, definitely. If a patient is still symptomatic, despite all the medical therapy that had been implemented, I would definitely see the patient in the cardiology clinic. Now, another point that I want to make here is if a patient has already had stress tests recently and the stress test did not show, I suppose, completely normal result, I probably would not subject this patient to another functional imaging modality. I probably would consider CT coronary angiogram, for instance, in this patient, because this is when we need to start using the combination of CTCA. We need to use the combination of anatomical based imaging and the functional imaging in order to help us to risk stratify this further. Okay, because otherwise, if we put them into stress tests, just like your point, if the stress test is normal, I'm still concerned with her symptoms. Yeah, I'm still not happy with the way she describes her symptoms. So the stress test might not help me in this kind of situation. So I would actually consider CTCA as assessment in this patient if the troponin is completely negative. Okay. Obviously, if the troponin doesn't quite meet the criteria of complete rule out, then I would definitely consider invasive coronary angiogram or something like that, given the story.
So in a short, that if its patients can't afford to have that CT coronary angiogram, that needs to refer to the cardiology outpatient clinic along with the risk factor modifications.
Yeah.
I have a question myself about the cholesterol management, that you suggest that this type of patients with the high risk, you put on a high dose the statin, so 80 milligram of atorvastatin or 20 or 40 milligram of rosuvastatin. When you repeat a blood test in 3 months' time and then results come up like a cholesterol is 2.8, triglyceride is 1, the LDLs come for 1.4. Do you decrease the statin at that level, or you just still continue that higher dose at that level?
I would still continue on higher dose at the level, especially if the patient is asymptomatic, because it means that your management works. In fact, there are increasing data which suggest that how low can you go with LDL, okay? So in fact, if a patient presents with ACS, then our LDL target is actually not 1.8, but actually less than 1.4. But there are more and more data shows that to make it less than 1 is even better. So therefore, the only decision-making point I would reduce the dose of the statin is if the patient starts developing some sort of adverse reaction to statin. Then that will be a time for us to review the statin dose. But if a patient is tolerating it well, patient is asymptomatic, I would leave them at that dose. Obviously, if after some time, let's say the dose, the LDL continues to go down, then you know what, we might make a consideration to actually make it into moderate intensity. But the guideline, if you read through carefully, rarely mandate changing of statin dose unless patients actually develop adverse reaction to the medication.
Okay. Great. And I have one more questions from the colleague that that colleague's got 80-year-old male patients with a background history of diabetes, gout, hypertension, and double vessels disease, and it's been successfully stented. This patient is not tolerating statin, despite that different changes in the doses and trying a different type of the cholesterol medications. So the colleagues wanted to know what are the options for to control, like reduce the cholesterols in this patient who is really high risk by the age and the risk factors and the previous event. What are the options we have?
You know, that's interesting you asked that question, because there are some data that shows the benefit of statin starts tapering away once it reach the, you know, octogenarians and onward. So it's rather interesting. Obviously, I mean, the issue with this patient, obviously, because the patient has had previous PCI, so ideally you would want to manage that. You know, in this context, it is not a straightforward question, but the way I view it is I will present options rather than mandate a treatment, because ultimately when you turn 80, really, you know, the goal of treatment is essentially quality of life, you know, rather than kind of mortality benefits, so to speak. Okay. And how I would frame my discussions running is, one, establish that the patient is asymptomatic. Now, in terms of options, obviously the options that he has is either you can go to ezetimibe, which is a slightly weaker statin, especially if the patient is diabetic. Then ezetimibe has some data in that role. Or the alternative, if patient's still not tolerating, is to consider the new cholesterol medication called the PCSK9 inhibitor. So things like evolocumab and things like that, which comes in injectable form. However, at the moment, in order to qualify for that, there is quite a regimen that the patient needs to jump. So for instance, patient LDL needs to be more than 2.6. And then patients would need to have symptomatic, you know, atherosclerotic cardiovascular disease and one of the following. Either patient had prior to event, or patient had severe multivessel disease, you know, diabetic, etc. Then patient might qualify for this thing. So there is actually quite a big hoop to jump. So really his options are, one, you put them on you know, ezetimibe. Second, you can consider on PCSK9 inhibitor if the patient meets the criteria. Or thirdly, if patient has not been tried on sort of, you know, in other words, if he's only been tried on one statin, which is rosuvastatin or atorvastatin, then sometimes I might re-challenge them again with another much weaker statin, such as pravastatin, because, you know, it's better to be on statin rather than not on statin at all, you know. So those are the three options that I would offer him. Now, if those three options are not an options, then I would consider either putting the patients on dual antiplatelet, for instance, if the bleeding risk is low, in order to mitigate the risk of event a bit more. So those how I would manage the patients. and I would do it on the basis of the patient's symptoms as well. In other words, if the patient is not that symptomatic, then it is not a strong push, so to speak. But if the patient is symptomatic, those are your options.
Right, thanks. Very comprehensive answer, Sam. Thank you very much. Let's move on to the fourth scenario. So that's a 35-year-old female. She's complaining of chest pain, which lasts for a few seconds, and she feels like a stitch, and it's well localized. Occurs at a very random time, not associated with this, any exercise. And she's obviously concerned about the heart attack, and that's why she comes to see the GP. Her background history is that she's not a smoker. She's regular physical, like a sporty person, play a lot of sports. So she had a possible rheumatic fever in the past, but she can't confirm it. With the assessment, her blood pressures come back normal, so BMI is normal. She had no family history of a premature cardiovascular disease. With your blood assessment, that her bloods were fine, except that cholesterols and the LDLs LDL and HDLs come back a little bit at normal. So here is the patient, 35 years, intermittent, short-lasting chest pain with no risk factors. So how do you assess this patient?
Well, clearly this patient's pre-test probability is extremely low, isn't it? Because this is clearly a non-anginal chest pain, and on the basis of her age and risk factors, her pre-test probability probably somewhere in the range of 1 or maximum 2%. So it's below 5% that I spoke about. So it is best not to do any imaging. When I say imaging, I mean like a stress test or things like that, because it might return a false positive test, okay? And probably she's a bit too young for calcium score as well. You know, you need to weigh in the pros and cons about giving them radiation when you're 35 and might be pregnant, who knows, right? So those are something that is important to bear in mind. However, given her possible rheumatic fever in the past, then it is not unreasonable for us to do an echocardiogram, because you want to rule out any presence of rheumatic heart disease in this context. And if the echo shows that the LV function is normal, then you can reassure the patients that, hey, your survival is pretty good on the basis of the ejection fraction, on the basis of the data that I've already shown you. And you can just reassure this patient that other than the echo, she doesn't need further investigation.
Right. Now, with the timing, like a duration of the chest pain and the coronary artery disease, is there any data or is there any duration that if it's a chest pain lasts for more than certain minutes or certain seconds, it can be a coronary artery disease, or it cannot be, like a less likely to be a coronary artery disease? Is there any data for the duration?
Yeah, so there are people that try to look into this before. I must say the data quality is not that great, and possibly because you would imagine it's very challenging to actually do this study, simply because patient's story keeps changing when you think about it, right? A story that gets told to one might be different. Having said that, there is a general rule of thumb. If a pain lasting only for a few seconds, almost likely it is not angina pain. That is actually the general rule of thumb. On the other hand, pain that lasts for days, hours, etc., and the troponin is completely normal, is also very unlikely to be cardiac as well, when you think about it, because obviously, if it were to be due to obstructive coronary disease, which we are kind of very concerned, if a patient has hours and hours or days and days, at least you would have expected the patient to have Q waves, for instance, right, on the ECG, and so on and so forth. So any extreme duration of chest pain usually is, less likely to be cardiac. But seconds, yeah, definitely, not definitely, but very unlikely for it to be cardiac.
Right. Very good. I think that's we come to the conclusions. If it's any questions, we can take it as final questions now. Jody, I wonder that if it's all the attendees, we can unmute them so they can answer, like ask the questions directly, or they can write it down in a chat box.
I'll give it a go of unmuting you all, but in the meantime, if you could please pop any further questions in your chat box, that'd be great.
Right. Thanks, Jody.
Unmuted.
Hello. Hello. Is there any questions? Anyone wants to ask any final questions?
Looks like we're all out of questions. Thanks, Bhavesh and Sam. Great presentation.
We covered all the topics. Excellent, Sam. Thank you very much for your time. It was very great educational discussions, and the topic that you brought a lot of wealth of knowledge about that coronary artery disease that we commonly face and worried about that are we missing any serious problems, underlying things. But it's good to have some sort of strategies and some sort of data behind it and knowledge about that's how to rule out the coronary artery disease. Really appreciate your time, Sam, and appreciate time from the Jody and Makala for setting up this webinar for all of us. And thank you all the attendees that's come up after your busy day, and I hope you learned some good lessons from here. Just finish your evaluation form. We will send out in an email. And if you have any further topics that you would like to discuss in the future, feel free to just mention it, and we can work on those future topics. All right, that's it for tonight. And yeah, thank you again, Sam, and have a good night.
Thank you.
Right.